All right, good morning, everyone. I'm Andrew, and today I'm presenting my final master's presentation on the development of a 3D printed phantom for total skin electron therapy dose assessment. I'd first like to take this moment to thank my supervisors, Dr. Pejman Rowshanfarzad and Zaid Al Khatib, who have been a big support in this project. So total skin electron therapy is a specific technique, radiotherapy technique, used to treat mycosis fungoides, which is a type of cutaneous T-cell lymphoma. So in this disease, we have infected T cells which migrate to the skin surface, forming symptoms such as patches and plaques, cutaneous tumors, reddening of the skin, and other visceral metastases. So at later stages, this can cover over 80% of the skin surface, causing a substantial impact to quality of patient life. This disease is compounded with the fact that it has a very rare occurrence with 5.9 per million person years. So in West Australia, we're only looking at a couple cases per year. As a result, availability of treatments is often limited, and this includes total skin electron therapy, which is not available currently in Western Australia. So this is a particularly challenging technique compared to standard radiotherapy because of its unique characteristics. We're aiming to treat the whole skin at once, so we need a very large field compared to small target tumors typically. This requires source to surface distances of 3 to 7 meters, which of course need to be remeasured. And of course, we're using electrons with high dose rate. So this is an example set up on the right there. So this treatment offers quite high skin dose and steep dose fall off with the penetration of electrons, of course, is quite small, so you get high surface dose. You have good long-term progression-free survival for early stages, as well as complete remission rates, which are very high in stage 4. Now, note for any treatment of mycosis fungoides, this is still palliative care and not curative. But total skin electron therapy can improve patient quality of life significantly. And it's also repeatable, allowing for multiple courses without too much toxicity. So what are the challenges of implementing total skin electron therapy? So one of them, first of all, is high patient-patient variation, as well as variation between different centers. So I've collated in this table a bunch of different studies from in vivo dosimetry for patients. So highlighted in blue are the ones that are most different. Now, it might be hard for you to read on the screen, unfortunately, but in particular, there's been correlations found between studies for obesity index, weight, and height for dose correlations. So for some areas, like the mid-medial thigh and the axilla, you can see this dose range is quite significant. So some patients will receive dose which is perfectly as is prescribed, while others will need a boost completely. Now, this is partially related to our treatment planning. When we do our treatment planning, this is mainly done with the anthropomorphic phantoms, such as the rando phantom, which is pictured here. Of course, with such phantoms, we have a limited range of measurements. For this torso and head region, these measurements are usually actually quite homogeneous compared to some of the limbs like the arms and legs. It also mimics the average male, where we can see there's quite a large variation with these results. And the largest issue is that we do not have a treatment planning software or Monte Carlo simulations really, which we can use for TSET, because we're looking at very complex surface geometry and far SSDs. And so this can lead to issues in our planning and actual treatment delivery. So I'm going to look at this case study in particular. So they first did calculations from the rando phantom and then used a body factor to convert this to the patient dose in terms of what they were predicting. Now, the problem with this lies with their first fraction, in which case they only delivered 78% of prescribed dose when they measured it with in vivo dosimetry. So they increased this and increased it again in the second and third fractions. But overall, you still have a 28% discrepancy between their planned and actual dose. Now, majority of this is due to the different patient body factor, which is the difference in the patient geometry from the rando phantom. So with that much discrepancy, it's going to severely impact our treatment outcomes. So this project aims to address that issue, especially in commissioning stages, which you are in for Sir Charles Gairdner Hospital. In vivo dosimetry is not possible, as there aren't any patients, of course, and setups between centers can vary significantly. So it's important that we determine boost areas, shielding areas, and dose at depth for our specific setup, including areas of extremities and limbs. And so this is going to be done with 3D printing, which we aim to establish accurate dosimetry for, and a good procedure in the case we can add patient-specific phantoms in the future. I'm going to quickly go into the model design for this project. So I used an app called Magic Poser. You have a bunch of nodes which you can rotate limbs around, and you can actually change the look of the model. So the final model gives us something like this. So I've added a little bit more fat, taken some of the muscle off, and put it in the intended treatment position at Sir Charles Gairdner Hospital, as given by advice from Zaid. So initially, this is quite low resolution. So I've gone ahead, smoothed it in Mesh Mixer, giving us this as our final result. So in terms of 3D printing, there's some of the settings listed here, but to avoid the main things, the main phantom is going to be a shell type model and filled with tissue equivalent gelatin inside. You do note that there is some wavy lines on the left image, and this is our gyroid infill. So normally we do have 0% infill, but gyroid will give us additional strength because we are dealing with a much heavier phantom, as well as a continuous volume which won't block any of the gelatin filling. So for this phantom, we've done a bunch of verification steps, and this includes percentage step dose curves. So mainly this is to determine the perturbation of the PLA shell. So we printed off a couple of different slabs with different thicknesses to measure the dose at different depth with a Riche chamber. We also repeated the measurements with gaff chromic film placed vertically. So between these measurements, this is the curve we got. We can see that we have quite good comparison between our agreement between ion chamber and the film measurements. And this is compared to a water tank ion chamber measurement. So in comparison, we have a lower Dmax than the water. So this does indicate that we have higher density of the plastic, which is expected for 100% infill. Between the 0 depth and the depth of around 15 millimeters for the maximum depth in water, we get an RMSE of around 4%, which is not too significant. In particular, for our thickness, which is only going to be 2 to 3 millimeters for the shell, there's minimal perturbation in that area, and even from the film curve, we can see that the surface dose is quite similar. We continued this verification with filament infill curves. So some areas such as the fingers and the toes are too small to reliably fill with gelatin. And so those have been printed solid instead. So we have a couple cubes with different infills and CT scanned them. So from our cube and line of best fit, the cube infill of approximately 90% best approximates a HU value of 0. Now you do note that there is a high standard deviation for that particular cube, but that was a print error and not particularly to do with the 90% infill. And then we continued this with gelatin verification. So the more gelatin we have by weight, the denser the gelatin is going to be and the higher HU. So from our curve, we've chosen a value of 5%, and this gives us around a HU of 20. So that's still in the range of soft tissue. It could be interesting to go further and a bit lower in terms of HU numbers, but at that percentage of weight by gelatin, we start to have issues with stability of the gelatin. So gelatin here was primarily used for its low cost, as well as established and commissioning in past projects as well, including Riley's and Rachel's projects. We also did a final surface dose comparison. So we did this with a rectangular prism phantom filled with gelatin and 3% infill, and compared the surface dose with film to solid water slabs. And so we get a relative dose on 97.5%. Now, including some uncertainty for our calibration curve and scanner, it's possible that the difference is not statistically significant. There is some difference still, but for most of our phantom, we're going to be taking measurements in terms of relative dose compared to our reference point, which is our umbilicus. So this is the completed phantom seen on the rotating platform on the right. There's a couple other issues that I haven't mentioned, which is the stability frame. So unfortunately, there's a lot of muscles that go into making sure we stand straight, which can't be simulated with a solid plastic model. So this frame will cause some extra scattered electrons in some areas and obscure the beam, particularly for the back and spine area. There's also the handlebar. So in Sir Charles Gairdner Hospital, the patients will be holding a suspended bar above, and that's going to ensure that they will be stable and won't fall during the treatment. So this will cause some additional shielding for the hands, of course, and that's what we're trying to measure with that. And of course, there's a rotating platform because we are going to radiate with a rotational total skin electron therapy method. So our dosimeter of choice primarily has been Gaphchromic EPT3 film. So with 0.28 millimeters thickness, we get quite accurate surface dose measurements without perturbations of the beam. It's quite energy independent in literature, which is quite useful for extended SSDs. Electrons will have quite a range of energy, largely tissue equivalent, and is readily available and convenient. So here we have over 50 measurement points with Gaphchromic film, which would be quite pricey with TLDs, for example. And Gaphchromic film has been used for in vivo dosimetry as well in literature for total skin electron therapy. We've also used it across some of the transverse measurements, including the abdomen here, the thighs, the head, and the thyroid. And so here we can measure the dose at depth and do some dose volume analysis and just check what the influence of surface geometry is in our particular phantom. So the dose volume analysis I've shown here is the isodose curves for the thyroid and the eyes, or head specifically, and I segmented out the area for the eyes and the thyroid. Going from a 2D dose map, I made the assumption that it's a uniform vertical dose and pretty much multiplied it by a pixel frequency for a sphere. So this brings us to the main results of our phantom. So I summarized it here in this table compared to literature values, which I showed in the other studies earlier. So key important factors, first of all, are the boost areas. So boost areas are classified as areas receiving under 80% of the dose, and hence require re-irradiation to ensure accurate positioning, essentially, and that we get sufficient dose to those areas to provide remission for the cancer. So this is the top of the scalp, top of the shoulder, the inner hand, perineum, and intergluteal cleft. So most of these are consistent with literature. In terms of overdosed areas, we have the outer elbow, the posterior knee, and mid-dorsum of the foot. So a lot of these values align with variations between literature. The most significant differences are the scalp, elbow, knee, and inner hand. So for the scalp, this one was quite a large difference at 29% in our study compared to around 80 to 90% in other studies. So those studies are using in vivo dosimetry. The main differences there is the presence of hair on the scalp, which is going to cause extra scatter, as well as primarily the use of TLDs, which have additional thickness compared to Gaphchromic film at the top of the head. And so that's going to lead to higher dose readings. We can double check this actual dose to the scalp with the use of an additional wig on the phantom. Now for the elbow and the knee, here's where I wish I could have the camera on, unfortunately, but for the arc-specific pose, the elbows are sticking a bit further out than most other studies. And so as a result, these elbows have shorter SSD, and you got higher energy electrons, contributing more dose to those areas, as well as being quite an angled area. The same is true for the knee. So these are specific point measurements for our setup, which are significant compared to other studies. We also have the hand, which was shielded, receiving quite a low dose. Because we also measured quite high dose variations for the fingers, it's advised that we shield the whole hand and then irradiate afterwards with a boost field for additional control in our setups. So this brings us to a dose heat map. So for visualization purposes, I've also drawn a heat map here. We've got the measured points shown as scattered points on the phantom map, as well as interpolation between those. So it's important to note that this is a 2D interpolation, and it doesn't factor into account any of the surface geometry, only points which are, of course, affected by the geometry. So with sufficient points, we can create an accurate map. And so that's true for some of the areas here. We can also evaluate this technique compared to other techniques, and it still provides a useful tool in our toolbox. So I want to compare this to other state-of-the-art technologies. So earlier I mentioned that Monte Carlo isn't really appropriate, and that to some extent is still the case. This was a study conducted last year, and this is with Monte Carlo, although it's a slightly different approach. So they first simulated dose to rotational cylinders at extended SSDs of 5 to 20 centimeters. Then they manually labeled areas of the body with a certain radius. So they said the torso was 15 centimeters, and projected the dose from the rotational cylinders onto the surface by multiplying with the cosine of a normal vector to a horizontal beam. So for example, for the head, that angle with the horizontal is pretty much 0, and you will get almost 0 dose at that area. In comparison to our results, you can see that that is true for the cold spots in our measurements as well as their results. Now, we do see some differences in the hotspots specifically, though. So some is due to the pose differences, like we said with the elbow and the knees, as mentioned earlier. But some are also just due to how we've actually measured our results and how they have simulated it. So for example, we have the ears and the nose, which receive quite high dose in ours, which are overdosed. For the nose, the penetration of the electrons will actually go through or extend through the nose, which means you get dosed from all sides when irradiating. This is compared to the Monte Carlo model, which just assumes that the complex geometry of the head is just pretty much a sphere or radius around 5 to 10 centimeters. And so small features like the nose and ears aren't simulated. This approximation, of course, gives you much more uniform dose compared to our physical measurements. We also suspect it doesn't include self-shielding for the inner thigh, which should normally receive less dose as the phantom is rotating, and doesn't simulate the field, which can have up to 10% uniformity, which is considered acceptable. Thus, our phantom provides a more comprehensive method to actually physically measure all these factors as well. So from this heat map, we've also calculated a pixel area and dose volume histogram. So in blue is the target area or our whole body. Now this is calculated from the dose map pixel values. So keep in mind that this is a 2D image of a 3D object, so it doesn't cover everything here. Nevertheless, from our results, we see good coverage of the pixel area surface. 90.8% is within plus or minus 10% of the reference dose, which is quite good. We have a small amount, 3.5%, requiring boosts, and 2.5% requiring shielding. Again, because it's a 2D image, it doesn't include the soles of the feet, which would increase the area that requires a boost. So the feet, of course, receive around 6.6% of the actual reference dose. In comparison, let's look at the organs at risk. This is the eye and the thyroid, which I mentioned earlier from our transverse films. 50% of the eye received over 60% of the dose. And while for the thyroid, 50% of the thyroid received over 90% of the dose. So for the eye, which has been simulated with radius 1.5 centimeters, we have much more significant depth, which is close to our penetration of the electrons. And so the dose areas there can vary a lot towards the back of the eye. Whereas for the thyroid gland is much smaller area, and the difference in penetration is not significant there. Now, for a total treatment course of total skin electron therapy, we're expecting between 30 and 40 grays. So for that amount, the thyroid can receive up to 27 to 30 grays even. So shielding is very necessary for both the thyroid and the eye. Eye shielding is established in literature, usually with lead shields under the eyelids, but it's likely also necessary for the thyroid, which hasn't been established yet. It's also probably necessary for the testes, which hasn't been tested in this phantom, but is also an area which is close to the surface. Typically, in the side effects for total skin electron therapy, it is reported that we do have quite a lot of male infertility, and sperm banking is advised normally. So additional shielding for the testes area can prevent that at the cost of some treatment effectiveness. This also brings us to percentage dose curves, which have been analyzed from the same transverse films. So we expect that differences in surface geometry will cause different penetrations. So on the left, as electrons collide with more oblique incident surfaces, you do get higher surface dose and lower Dmax. So here we have our abdomen profile again, and I've shown where I've taken these profiles. And so this gives us these curves. So I've analyzed these in MATLAB. I'd first like to go through some issues. First of all is our dose at depth measurements, which said 6.6%. So we know from electrons that this dose should pretty much have fallen off to 0, and you can see it flattening out. And even X-ray contamination should be lower than 2.4%. So this reading is likely just due to our calibration curve for the film not extending enough to low depths sufficiently, which is unfortunate. And in particular, we can see for this front abdomen curve that actually stabilizes at around 20%. So in particular, that has had some either warping of the 3D print, preventing, increasing the amount of air gap in that area, or particular piece of film that had an issue there. So in terms of analysis, For the spine, we can see that this has the lowest max energy and max dose at the surface. This is primarily due to the post-median furrow, which is shielded from either side, as well as scatter from the stability frame, which introduces some lower energy electrons. And so that's why we get a higher surface dose and no buildup really. The side is similar. With the smallest effective radius, we expect it to have high surface dose and then no buildup. And for the front abdomen and the lateral back, they have both got similar Dmaxes. The lateral back has higher energy and higher max energy, typically because of the extra scatter, we presume. But it's also due to the placements of the film, as well as just the accuracy of how far it extends out. So I'm going to compare these front abdomen curves to some more calibration measurements we did. And so this was done with a rotational cylinder as well as a rando phantom. So the rotational cylinder is approximately 15 to 20 centimeters radius from the top of my head. It was also 3D printed and filled with gelatin without any infill inside. So that should give us a more accurate dose, as well as the rando phantom. So between the rotational cylinder and the front abdomen curve, we see quite similar characteristics. So the Dmax is approximately the same, although our fall-off dose for that front abdomen is a bit problematic. In comparison to the rando phantom, we see that the rando phantom has a Dmax of 1 millimeter, which is much shallower. So for this, we primarily believe the reason is due to different tissue surface geometry. So for the rando phantom, it does simulate a slightly skinnier patient compared to our phantom, as well as the cylinder, which will have more curved surfaces. In addition, there's the potential for different phantom density, while our phantom and the rotational one are both a shell design with gelatin inside. Another important criteria that we have to meet is our depth doses at 4 millimeters and 20 millimeters. So from the European Organization for Research and Treatment of Cancer, for the guidelines of total skin electron therapy, it's advised to have at least 80% dose at 4 millimeters and under 20% dose at 20 millimeters. And so this is, of course, to ensure we have sufficient dose to the target area and less dose to organs inside. So unfortunately, none of our measurements really reached that 20% margin. So the rando phantom is just above 20%. And so this is primarily due to our decision not to use a beam spoiler as well as a scattering foil. So normally they're used to increase uniformity. So our uniformity was deemed sufficient without it. But of course, that does mean that we do get slightly higher doses at depth, which is something we have to potentially consider again. So I'm going to quickly go over some phantom review in terms of performance, cost, and convenience. Now, the main issue is the cost and convenience. While the financial cost is not significantly high, with $575 compared to a rando phantom, for example, the time cost is quite significant. So for the phantom, it took around 20 days of printing time. That's, of course, split across 3 printers, but that is time that can't be used to print anything else. Again, there's also the assembly time. Due to its weight, it does take 2.5 hours on the day we assembled it with 4 people, including placement of all the different films. So that should be reduced when we have less films, as well as only required infrequently. So for example, we're doing commissioning now, but in the future, you're only going to have a few treatments per year at most. So this is a limitation of the phantom. Patient-specific phantoms are possible. We can obtain laser scans of patients in the correct poses and then print it off from there. But with the time consumption, it's not feasible really to wait 30 days before treating the patient after they come in for a prescription, just waiting for a phantom to be produced for one-time measurements. So in that case, it reduces the amount of in vivo dosimetry, but does not replace it. So the main takeaway is where we can actually place and where the main warning spots are, which are, for example, the elbows. Thus, it's most useful in commissioning. We've also assumed that doses that the tissue is homogeneous within the internal regions. So that's going to affect primarily our depth doses, and to a lesser extent, some of our surface dose scattering. So future advances in 3D printings can reduce this time, but it's still somewhat limited. So we're looking now at printers which can print around 3 to 5 times faster than what we have, but it's still a significant time cost and maintenance. In any case, this brings us to our conclusions and clinical implications. The main key findings are specifically the dose distributions for the Sir Charles Gairdner hospital setup and leading to placement of in vivo dosimetry in accurate areas. So this enhanced treatment planning can lead to more precise planning and reduced side effects based on our shielding decisions. And this can improve our treatment outcomes with, of course, minimal toxicity. This data also allows us to really consider if we need to change our treatment position and how we can optimize this technique at Sir Charles Gairdner Hospital specifically. In terms of recommendations, we can consider the beam spoiler and scanning foil. We can also look at bolus shielding as a means to minimize side effects. So this is primarily for the gonads region, as mentioned earlier, for the males. So typically lead shielding can be used, but then it will cause additional X-ray contamination as we are dealing with electron beams. And so boluses can offer a way to reduce this without too much X-ray contamination. Some other considerations are the wig measurement, as mentioned earlier, as well as gel dosimetry to reduce positioning errors from some of these areas. Presently, this research represents the sole comprehensive method for commissioning process in terms of getting actual measurements across the whole body without in vivo dosimetry. And so thus, this is quite an important step. So this can lead to, in the future, of course, studies where we can actually make patient-specific phantoms in reasonable time, considering advancements in 3D printing. But for now, this is the best way we can do it, as opposed to Monte Carlo, which is still being developed at the moment, or anthropomorphic phantoms, of course, which are quite limited. Yeah, that's pretty much it for my presentation. There's some researches here, references here. Thanks for listening all. Are there any questions?
Well done, Andrew. Great presentation. Is there any questions for Andrew? Ari, go for it.
Hi, Andrew. Awesome presentation. I was just wondering if another student was to undertake such a large amount of printing, is there any recommendations you have?
Yeah, so a lot of time can be saved in properly setting up the printers and establishing those, for example. But in general, it would potentially be an important factor to consider the reusability of a phantom. So for something like this, especially since we're looking at surface doses only, it would be interesting to consider such like an internal frame and then patient-specific attachments for, say, like the stomach, for a wider stomach or a smaller stomach. And that would save time in the future of having to reprint phantoms and all. So I think in the long term, that would be ideal. In terms of settings, it's just the standard 3D printing settings in terms of maximizing your volumetric flow by increasing your nozzle size.
Thanks.
Martin, have a question?
Yeah, that was really comprehensive, Andrew. Thanks for that. I think the first time you mentioned spoilers was in the context of the depth dose measurements.
Mm-hmm.
I guess the first question is why did you choose not to use a spoiler? And then I guess just for the people who aren't familiar with them, maybe just explain what it is and how it works.
Yeah, sure. So on the bottom right here was a typical image of another setup at another center. So here there's a polycarbonate scattering field here, beam spoiler here. Normally, because we are at a distance of 3 to 7 meters, the field that you create is only between around 120 centimeters in height. Now we actually need a field of 200 centimeters. And so while we have a dual field, which is created by a gantry angle below the horizon and slightly above the horizon, this can still create hotspots, and that low uniformity of the field is hard to apply to the actual patient. So to solve this, typically methods have been using such as scattering foil, which is placed in front of the beam, or this beam spoiler here. So this in general scatters the electrons. So we have lower energy electrons causing a higher surface dose and lower penetrations. It also increases the uniformity because the scatter, of course, scatters it in a larger area. So we do expect that with a beam spoiler, your treatments are going to be slightly longer to achieve the same doses, but it increases uniformly and decreases your dose at depth. For our setup here, it was chosen that spoilers weren't necessary, primarily because of the uniformity that we could achieve in our setup without needing the spoiler. So we achieved margins within 10%, both vertically and horizontally, which was the criteria needed from the organization of EORTCs. That being said, it could be a consideration because our dose at depth is slightly higher, or additional shielding for some areas at depth, like the thyroid, for example.
Okay, thanks.
Any other questions for Andrew? Andrew, with the shielding considerations, I was just wondering if, with the shielding that would likely be implemented, would that reduce the dose to, for example, the eye, such that we wouldn't have any adverse effects on the eye? I mean, we did just hear Ari's presentation about the prevalence of cataracts even at really low doses.
Yeah. So there's potentially going to be some cataract still. So in the guidelines, it's specified that the dose to the actual eye should be less than 0.7 grays. And so for that margin, you can still see some symptoms. For this treatment, it's considered acceptable still. It does reduce it to below that amount in standard procedures. There's other areas as well, which they... Sorry, I've lost my track. Does that answer the question?
Yeah, that's all good. I was just wondering if, you know, the shielding that you would likely implement would reduce that dose, or if it's just, you know, sort of accepted that you're going to have some side effects for the eye in this case.
Yeah, sorry. So you'll potentially have some, but yeah, the limitation is 0.7 grays. And so standard lead shielding does provide that for the eye, although you do get additional backscatter towards the eyelids. And so that eyelid region does normally get higher dose.
Great, thanks, Andrew. If there's no other questions, then I think we'll leave it there. Thanks, Andrew, again for your great presentation.
Thanks, everyone.
And that brings us to the end of the first part of our master's presentations today. So if everyone would like to have a short break, we'll be recommencing at around 12:30. So there's 40 minutes break before we restart.